so we can make a follow up.
Yeah, all right. Now it is already there. You can just go. We are live on Facebook and now on YouTube. Initially we're not live. Now we are live now. So you can just search my name, or even when you get to Facebook, you just search my page. You're gonna see that we are live.
Yeah, what I was saying,
No, there is no
just
link. There is no
to
link to
share
the
my page.
there is no link to the Facebook account. To the Facebook account, except for the YouTube. But at this time now, we cannot share it.
Okay. All right. Thank you.
Okay, thank you. Um, Thank you, everyone. Thank you, Miss Mercy Cooper, for leading us with that powerful prayer.
Have I tell you already?
And I hope everyone can see me. Can hear me. So we can start our live event now. Again, I would like to welcome everyone in this Dr. Elvis Oncology Talk. This is the 7th Virtual Cancer Awareness. Thank you everyone for joining, and if you can please put your comment, your name in the chat, and say which side are you hearing us from. Yeah, but also I would like to give a more elaboration of this event. This event is always live on the last Sunday of every month, and it's a virtual cancer awareness, which is live on 3 platforms, which are Google Meet, YouTube, and Facebook. So at the end of the last Sunday of every month, you can just find us through those platforms and be able to join our meeting. So without wasting time, I will jump directly to the objective of our meetings, as well as the expected outcomes of our meetings. So starting with the objective of our meetings, the objective is to increase public awareness and understanding of cancer prevention, early detection, and treatment options through engaging and informative visual materials, aiming to encourage healthier lifestyles and proactive health-seeking behaviors. And then our expected outcomes are greater public knowledge of common cancer types, their risk factors, symptoms, and the importance of early screening. And then our next expected outcome is more open conversations about cancer, reducing fear and misconceptions which surround the cancer disease. Also, the other expected outcome is increased willingness among participants to seek professional support when needed. So we would like to welcome you all in this visual cancer awareness. I appreciate all those who are still sharing the links so that we can have more audiences for these important things that we are going to learn today. And so now it is the time for me to introduce our speakers who are going to present to us tonight. Today is a unique event because we are going to have two presenters who are going to talk with us different cancers. So starting with our first speaker tonight. Our first speaker tonight is Dr. Lusayo Vita Simwinga. Dr. Lusayo Simwinga is a clinical oncology resident at the Ocean Road Cancer Institute. She's going to talk with us to present us the two cancers, which are the pancreatic cancer together with the gastric or stomach cancer. So I would like to welcome Dr. Lusayo. Dr. Lusayo, we are warmly welcoming you. And for everyone who are still joining, we would please wish you to turn off your mic so that we can listen attentively to our presenter. And for those who will have some questions, will be allowed to ask their questions later. There will be a time for question and answers. So please, you're warmly welcome, Dr. Lusayo. Welcome.
Thank you so much. First of all, I'd just like to, if my audio is okay.
Yes, we are hearing you.
All right. Um, okay. All right. So I'd like to be allowed to share a screen.
Can you share your screen from your side, or you want me to share from this side?
Let me try to share it.
Okay.
So, to share. Are you able to?
Yes, we can see it. You just need to put it
All right.
in the PowerPoint presentation, and it will be much visible.
All right. Okay. Okay. Do you mind sharing from your side,
Okay.
Dr. Elvis?
All right. All right. Let me try to do that.
Okay.
Just a minute.
Are you able to put it? Okay. All right. Thank you so much. Once again, thank you for the kind introduction. As you've already heard, I'm a clinical and I'm doing my practice at Ocean Road. So please next slide. I'm going to take you through the briefly, I'm going to take you through the awareness on stomach as well as pancreatic cancer. So first of all, we're going to look at the stomach cancer. So just a brief introduction on the epidemiology. So stomach cancer is the fifth commonest cancer worldwide. That's according to Global Cancer. And in 2022, we had approximately 970,000 cases. It, not only is it the fifth commonest cancer worldwide, but in terms of cancer deaths globally, it is also fifth, contributing about 660,000 deaths. That was as well in 2022. That's the most recent data that we have. In terms of the genders, how it affects the genders, we know that it is about twice common in males compared to females. The highest incidence is in Japan, and we will later on look at why this is the case. It is mainly common from the fourth to the fifth decade of life. So that is the brief introduction. The graphical presentation that is on the right, it's pretty much showing that the stomach cancer is coming fit. So it is with the other cancers coming ahead of it as lung, breast, colorectal, prostate, and then it is fit. So next slide. So this is also just for us to appreciate the epidemiology in terms of incidence as well as mortality. So we can see from the stomach cancer is coming fifth, and in terms of mortality, stomach cancer is also the fifth leading cause of cancer deaths. Next slide. So when we zoom in on West Africa, we see that in males, stomach cancer is still number 5. So that you can appreciate that the cancers that are coming before it are not exactly the same as when we were looking at the worldwide statistics epidemiology. So in East Africa, stomach cancer contributed about 4,000 new cases. That was in 2022. That was in males. In females, stomach cancer is not highly ranked, so it's not in the first. It's not in the first 5 cases. It comes about after the 10th, after 10, the 10th commonest case. 10th commonest cause of cancers. But if you combine both sectors, we find that prostate cancer is the third. So stomach cancer is the third. But in the males, it's the fifth. If you combine the cancer, the both males and females, we find that stomach. Sorry, in both sexes, we find that stomach cancer is number 10. So on the list, that's why it's not showing on this list, because this list is only taking into account the fifth commonest cancers. So when we combine both the sexes, we find that it's the 10th commonest. So when we look at Liberia, because I just zoomed in on Liberia because I believe most of us in the audience are from Liberia or East Africa. Yeah, so I tried also to get some statistics zooming in on Liberia. So in the males, we find that stomach cancer is the fourth commonest cancer, contributing about 74 cases. Those are new cases as of 2022. And in the females, stomach cancer is the fifth. Yeah, so it's the fifth. But if you look at the cases, the number of cases, 74 in males and 66 in females, we see that the difference is not as much, but we can still appreciate that in the males, the stomach cancer is still is more common compared to females. So we will now look at the risk factors and some preventative measures that we can employ in this fight against stomach cancer. So it is known, according to research, that the most prevalent or the most prevalent cause of stomach cancer is the infection of Helicobacter pylori. So a chronic infection of Helicobacter pylori is what mostly leads to the development of stomach cancer. There are other risk factors that are as well important, and we can look at smoking. We know that smoking, smoke from cigarettes, mainly from cigarettes, it contains carcinogens, or these are cancer-causing compounds that are able to irritate the DNA, thereby causing DNA damage that will eventually may lead to the formation of cancer, which is abnormal growth of the cells. So if the Helicobacter pylori infection is not treated, is not well treated, the chronicity, that long duration of exposure to H. pylori infection, it increases the risk of developing stomach cancer. We also know that age is a risk factor for H. pylori because it has been explained that um, uh, because cancer is usually not just from a single mutation, so it is from multiple. It comes about secondary to multiple mutations. So the older a person grows, the more the mutations accumulate. Because at any given point in time, our bodies are undergoing, DNA is undergoing certain mutations. Some may be detrimental, others may be repaired. But the older a person grows, the more the accumulation of mutations, and thereby the more the risk of developing stomach cancer. Some of the other causes that we may also want to look at is history of cancer, stomach cancer in the family, and then the other important cause risk factor is the consumption of smoked or salty food. So as I had already said in the first slide, that stomach cancer is is quite common, is quite prevalent in Japan. Uh, this is because it is known that in Japan there's a lot of consumption of um, this has, on the right side is just some of the preventive tips for stomach cancer. So the risk factors that we've talked about on the left, some of them are captured on the right. So we know that smoking is a risk factor. So quitting smoking has been shown to reduce significantly the risk of developing stomach cancer. Alcohol is also limiting alcohol is also one of the risk factors that can be modified. Balanced diet as well as physical activity. These have been shown to modify to reduce the modifiable risk factors that we have discussed. On family history, there is not a lot that we can do in a lot of centers, but in other high-income facilities or centers, there is actually genetic testing. If there is a genetic to find it, if there is genetic predisposition, especially if there is a strong family history of stomach cancer. Next slide. All right, so we are going to look at the signs and symptoms because we believe that if we're learning about the certain condition, we need to know how the patient is going to present to us or how we're going to carry out awareness activities in the communities. So we need to know the signs and symptoms that our patients are going to present to. So these signs and symptoms, they are mainly due to the local effects of the disease. So that is in the stomach as well as the gastrointestinal tract. And then the leg effects are systemic. So the systemic effects of the cancer on the body. So for the early effects, you have nausea and vomiting, which is quite common. You may also have upper abdominal pain, heartburn, indigestion, as well as bloating. This may be due to pressure effect as well as inflammatory effect of the cancer on the stomach lining. Yeah. So the late effects, we know that if a patient has stomach cancer, there's going to be malabsorption, poor absorption of food. So if there's poor absorption of food, the patient is going to have weight loss. Is going to present with the unexplained weight loss. They may also have anemia. Anemia due to the poor absorption of nutrients itself. It may also be due to the inflammatory effects of the cancer on the system. So, patient may also present with may also have cut blood in stool. This is blood that may not be very, may not be easily visible to the naked, or it may be passed out in stool, or it may be it may be like blood in vomit, or vomiting from blood. So these are some of the signs and symptoms that you need to look out for. Next slide, please. So what can we do? Having discussed the signs and the symptoms, the presentation, how best can we help our patients? Because we believe that mainly public health screening can effectively prevent some of the late presentations. Unfortunately, in stomach cancer, there is no standard routine screening test available that has been approved. So it is not routinely advisable to take a general community or invite the general population to come for screening for stomach cancer. One, because the stomach cancer itself has low incidence, as we already saw that we have about 900,000 cases, that is worldwide. So that is taken to be, that is viewed as low incidence. So if we try to find stomach cancer just by basically screening everyone, it may not be very economical as well, and there are potential risks that are associated with the procedure. So in those individuals whereby the screening is actually indicated, there are potential risks that are associated with the procedure. So the procedure that is done is the upper endoscopy. So an endoscopic tube is passed down from the mouth into the esophagus all the way until it reaches the stomach. So if there are any signs of inflammation, or there may be a tumor that is seen, a biopsy can be taken from there. But as we have already discussed, that this is not a routine test. So which individuals can benefit from this screening with an upper endoscopy? So mainly we consider those older people with chronic gastric atrophy or pernicious anemia. So gastric atrophy, it can be a side effect of, it can be a complication of H. pylori infection, which is one of the risk factors that we've already discussed, as well as pernicious anemia. So pernicious anemia is anemia that is mainly that is secondary to an autoimmune condition whereby the stomach lining is destroyed by the immune system of an individual. So when the immune system is destroyed, this leads to malabsorption, and basically anemia also happens. So if tests that have been done, and we see that this patient possibly has a pernicious anemia, and is an old individual, it may be indicated that we should do the screening procedure. And if there's also like strong family history of the disease, as well as predisposing. Next slide, please. So how do we diagnose stomach cancer? Stomach cancer. So pretty much when a client comes to us, thorough history and physical examination have to be done. So in the history, we have to make sure that we actively ask the questions according to the risk factors that we have seen, the signs and symptoms that we have seen, and following that we do a thorough physical examination. So in the physical examination, we may find that maybe the patient has a lot of pain, has tenderness on the gastric region, or they may have a tumor that is or a mass that is palpable. Following that, we can do an upper endoscopy. So the same screening procedure that we talked about, it is also used as a diagnostic investigation. So when the upper endoscopy has been done, a biopsy can be collected. And even before we confirm the diagnosis of the stomach cancer, there are further tests that can be done. We can do a blood test like the fecal occult blood test. So this is a checking for the occult blood in the stool. We can also do further imaging. For example, we can do a CT scan. We can do blood test to find H. pylori if the patient has H. pylori infection. And we can do MRI. Yeah, so MRI will basically tell us if there's any spread of the disease and which regions. So I should mention that there are quite a number of uh, different types of stomach cancers. So we may have lymphoma, we may have squamous cell carcinoma, but the most common type is adenocarcinoma. So adenocarcinoma is the most common type of stomach cancer. Next slide. So maybe we may have other people that are not in the medical field. Adenocarcinoma simply is it means that the cancer is coming from a gland producing glandular cells. So if it's a gland, like for example, like the salivary gland or um, or any cell that makes up a gland, that can become an carcinoma. So the treatment and outcomes, basically in stomach cancer, we have different modalities of treatment. We may do surgery, chemotherapy, radiation, as well as targeted therapy. So surgery is aimed to cure the disease. So if the disease is localized or it has not invaded other systems, surgery may be the treatment of choice. But chemotherapy is a treatment of choice if there is any systemic spread or if there's any metastasis of the disease. So when we're treating a systemic disease, we can employ chemotherapy. Radiation is also a good treatment choice because radiation helps to manage the local symptoms. It can manage the pain. It can also manage the tumor itself, or even if the patient is bleeding. Radiation is very good for that. But I should also mention that usually the patients are not just treated with one approach. Usually these approaches they may be employed together concurrently as well as in series. So we may have surgery and then chemotherapy, or we may have chemotherapy and radiation. So on the right side, these are just some of the observed survival rates. So as we can see, the earlier the disease, so stage one pretty much means that the disease has not spread. But if we go all the way up to stage 4, then the disease has gone systemic, so it is affecting other systems in the body. So the lower the stage of the disease, the higher the survival rate. But unfortunately, most of our patients become advanced disease. So the survival rate that we see is usually less than 20% in 5 years. Next slide, please. So I have reached to the end of the first part of my presentation. So what I would like to stress on is that as we as we all may know, there are cancers with approved screening strategies, and they, that actually benefit the population. Unfortunately, in stomach cancer, there's no approved screening, so let's focus on the high risk groups. And the early detection is key to improve outcomes, because we know that the more invasive the disease, the more difficult it is to treat. So every management plan has to be tailored to patient needs, because stomach cancer it has quite poor survival rates. So if we ignore patient needs and try to treat the disease as aggressively as possible, we may find that we're not giving any benefit to the patient, but we're even reducing the survival rates that we're trying to improve. So sometimes it's important that when we come across a patient with stomach cancer, just like any other patient with cancer, it is important to tailor the management plan to patient needs. Post them in the chat. So, um, without giving you too much information in a short time, I'll try my best to be very brief and straight to the point. So I'm also going to take you through. I'm also going to take you through the pancreatic cancer. So this is the outline of the next presentation. Next slide, please. So, what is the pancreas? So basically, the pancreas is an organ in the GI that in the gastrointestinal it makes up part of the GI system, and it has exocrine as well as endocrine factors. So I'm going to explain what exocrine and endocrine functions are. So endocrine functions, the pancreas is able to secrete hormones that regulate blood sugar. So the exocrine, basically, the pancreas secretes enzymes that help the stomach and the GI digest food. So the pancreas it lies between the stomach and the spine. That's the backbone. So it is partially behind the stomach, and it rests in the curve of the first part of the intestine called the duodenum.
Next slide.
So yes, next slide please. So as we have been discussing, abnormal cell growth is what causes malignant tumor formation or tumors or cancers to form. So abnormal cell growth of the cells of the pancreas may lead to malignant tumor formation. So the tumors that are going to form will be of exocrine origin as well as the endocrine origin. So yeah. So we have already briefly discussed the functions of the exocrine as well as the endocrine. So the exocrine tumors, these make up more than 85% of all the tumors of the pancreas. So the exocrine tumors, they start in the tubes of the pancreas. So the tubes are also known as ducts. So ductocarcinomas, ductocarcinomas are the most common, but you may also have carcinomas. So carcinomas are from the cells of the are from the cells of the exocrine part of the pancreas, but the ductal adenocarcinoma are from the ducts, the pancreas. And the endocrine tumors are also known as endocrine tumors. So if we have an endocrine tumor, that means it is a tumor that is secreting hormones in excess. So because we know that the endocrine function is to secrete hormones that regulate blood sugar, the tumors of endocrine origin are going to be insulinoma as well as glaucoma. So insulinoma, as the name is, it means that it's a tumor that is producing a lot of it's producing insulin in excess. So because of that, a patient may present with symptoms of low blood sugar, because we know that insulin is what helps to lower the blood sugar whenever a meal is taken. Next slide, please. So a bit of epidemiology. In terms of incidence worldwide, yes, pancreatic cancer is rated to be number 4 in terms of the commonest, in terms of the commonest cause of cancer. In 2022, we had about 410,000 cases worldwide, and it's the however, in terms of mortality causing death, it was ranked as number 6. So we can see that even though the incidence is not as much, but in terms of mortality, pancreatic cancer has quite poor prognosis, because even though it's not occurring as frequently, but it's still the 6th commonest cause of cancer deaths. The median age is 71, so that just tells us that we usually find pancreatic cancer in older individuals. Next slide, please. So this is what I've already explained in terms of incidence. We find that in Asia, that's when we have the most number of cases, most number of incident cases of pancreatic cancer. The prevalence, obviously, you also expect that Asia will be the leading. And in Africa, Africa is yeah, Africa is rated as number 5 in terms of its contribution to incidence, mortality, as well as prevalence of pancreatic cancer. Next slide, please. So zooming in on like area, we find that pancreatic cancer so in terms of in terms of its rank in the number of cases, cancer cases, it's rated as number 13, and in terms of deaths, it's ranked as 11th. So we can still appreciate that even though the number of cases are not coming up as commonly as the other cancers, but in terms of the number of deaths that are happening, it is from the cancer deaths. Let's proceed. Next slide, please. So what are the risk factors? We should always look at the risk factors so that we can appreciate which risk factors can be modified, and which ones we just need to carefully look out for. So in terms of the risk factors, the one that is the most important, one of the most important risk factors is smoking. So smoking greatly contributes to pancreatic cancer. But the other one that we should not ignore is pancreatitis. So that's chronic pancreatitis. Chronic pancreatitis is one of the leading risk factors for the development of pancreatic CA. Occupational exposure, this is exposure to pesticide in the metal waste factories. It has been shown to contribute about 12% to the number of pancreatic in terms of pancreatic. A lot of people inherit in a genetic component can also not be ignored. So what are the signs and symptoms of pancreatic cancer? So as it is with a lot of GI malignancies, we expect that the patient may have abdominal pain because the pancreas is quite a deep organ, so it's not superficial. So it may be difficult to that the patient is going to come to us, is going to be sent to the hospital, complaining of a mass, abdominal mass, but the patient may complain of abdominal pain. Maybe the liver, the intestines, or the stomach. So any pressure symptoms that are originated from these organs is what the patient may present with. So if the pressure symptoms are on the liver or the gallbladder, the patient may present with jaundice because of obstructed flow of bile. And if the patient, because we know that the pancreas is contributing quite significantly to digestion. If the digestion if the digestion is disturbed, if the patient the person is going to have malabsorption, and because of malabsorption, there's going to be a lot of weight loss. So we say drastic weight loss. Because of the same reason that the pancreas is contributing to digestion, any compromise in the digestion, the patient has digestive problems. So sometimes the person is going to come to you and say that I'm seeing a lot of fat in my stool. So like there's a lot of oil, but it's like oily stool. That's something that we present with. We tell that they have like oily stool because we know that the enzymes that are needed for fat digestion are compromised because of the same issue of the pancreatic CA. The patient may also, as we already said, the patient can have symptoms of low blood sugar, or it may be diabetes in some cases because of the same function, deranged function of the pancreas. Next slide, please. So how do we diagnose pancreatic cancer? Pancreatic cancer, first of all, when we have enough suspicion based on the history as well as examination, we are supposed to do a CT scan. So this is an imaging that is able to show us it's able to show us masses or tumors of the pancreas. So when we do a CT scan and we find that there is a suggestive tumor of the pancreas, the next thing that we can do is a fine needle aspiration. So the fine needle aspiration can be done, or we can do a surgical section based on the size of the tumor. So when we do the surgical exploration as well as section, then the sample can be taken for pathology, and we have our diagnosis. Apart from this, we also do blood workup. We also do blood workup because, as we already discussed, the tumors may be of exocrine component or endocrine component. So if it is of endocrine component, there are other tests that are done in order to check in order to check the component of the tumor. Yeah, in order to check the component of the pancreatic tumor that is in question. So on the right side, it's just briefly showing us the stages, the presenting stages. So as we can see, the common presenting stage is stage 4. It's about more than half of more than half of the patients are presenting already in stage 4. So that is quite advanced disease, and this explains this explains the poor prognosis as excuse me, this explains the poor prognosis. So late presentation is not always due to delayed presentation, because as we already discussed, the pancreas is quite a deep organ, and secondly, there may be non-specific symptoms. For example, a patient can go to the hospital and then they are checked, they have low blood sugar. It may be seen as an isolated case of low blood sugar, so the patient can be treated and sent home without further investigating why the patient is actually having low blood sugar. So because of the non-specificity of the symptoms, sometimes the stage of diagnosis is going to be quite advanced. Next slide, please. So the treatment options for pancreatic cancer are pretty much similar to stomach cancer. So the only curative, the only the only curative treatment option is surgery. However, because that we know that the stage of presentation is usually advanced, most patients and most patients are not done surgery because the disease is already be advanced, and usually chemotherapy or radiation and targeted therapy are what are going to be employed for the patient. So upfront surgery is the only curative option indicated in any disease. On the same subject of treatment, we need to understand that there is need for multidisciplinary approach for the treatment of pancreatic cancer. As we have seen, the patient is going to have a lot of derangements in terms of absorption, digestion, and whatnot, because the enzymes the enzymes are in short supply. So we need to involve the nutritionists and the dietitians as soon as possible. So some of the interventions that they can do, they can give the patient pancreatic enzyme replacement therapy. So in short, it's PERT. So these are enzymes that help in the digestion of the food. So the patient is able to take the enzymes together with the food, so that it aids in the digestion of the food. Next slide, please. Yeah. So pancreatic cancer has complications, of course. Uh, as we have seen, there's going to be pancreatic insufficiency leading to malabsorptions. There may also be bile duct obstruction leading to some of the signs and symptoms that we've already discussed, as well as some small intestine obstruction, because the pancreas is quite a central organ. So it may bring obstruction to the liver, it may obstruct the stomach, it may also obstruct the intestines as well. So the survival rate of the 35 years overall survival of pancreatic cancer, we see that if the disease is alive, that's when we have promising survival rates up to about 40%. But if the patient is presenting with distant metastasis, that is advanced disease, then the survival is pretty much less than 3%, as we have seen. Next slide, please. So just a bit of a summary, as well as just to touch on some of the key things that we've discussed. Treatment of pancreatic cancer is multidisciplinary, because unlike the stomach cancer, it is not going to be every. It is the digestion component will be very much affected from the pancreatic cancer. So there is need that when we see the patient, we involve different teams that will help the patient to have better disease outcomes. So and also because of the severity of the disease itself, we need to make sure that the patient, if the palliative team is involved, early on to discuss the prognosis as well as to discuss the treatment options. Sometimes the patient may decide that I do not desire to be given any chemotherapy or any sort of invasive treatment because, as we have seen, the outcomes are quite poor. So it is always important to discuss the treatment options that we have as well as the patient needs. Thank you so much. Uh, the next slide has my references, and I'd like to thank the organizers for the opportunity. Thank you.
Thank you very much. Well done, Dr. Lusayo. Thank you very much for a
Thank you so
wonderful
much.
presentation. For this time, I would request everyone who is having a question to kindly keep it because we will have much time for question and answers later. So right now, if you allow me, we can proceed to our second presentation, whereby we are going to have our second presenter. And I would like to introduce you. Our second presenter is Dr. Malonja Magaluda. Dr. Malonja Magaluda is a clinical oncology resident at the Ocean Road Cancer Institute. He's going to speak with us about the lung cancer. Dr. Malonja, if you hear us, we honorably welcome you. We honorably welcome you, sir. Please welcome.
Good evening, everyone.
Good evening.
Good evening.
For those who want to join, kindly tell them to join because if Dr. Malanja has an issue to present, it might be difficult for me. You can go on, Dr. Malanja. You can present from your side, I guess.
Yeah, okay, sure.
All right, thank you.
Okay. Good evening once again. Hello, I hope you
Good
can hear me.
evening,
Yeah,
Dr.
we
Malonja.
are hearing you. We're hearing you.
Okay, Malonja Magaluda, clinical oncology resident from which is from Tanzania, East Africa. So it is to join today and to on the. So just a
The
reminder.
line is a little
Doc,
bit bad.
your internet is a little bad. Maybe you could change your location because your internet, you are coming in broken. We're not getting you clearly.
Okay. It'll be difficult to change the location. Can you get me clearly right now?
Yeah.
Yes.
Yes, I can. From
We can get you for now.
clearly.
We can get you now.
Okay, sure. So November is a lung cancer awareness month. So just a thought that no one in the world deserves lung cancer, because in some cases it is preventable. So this is a bit history of all took place in the early, started in the 19th century. Cigarette was being described as the safest ever, that can bring good emotions and can make you feel things. So it was even recommended by marketers, that marketers were being paid as doctor to promote that it is safe to smoke cigarette. This went on until it was observed that there were cases of that were being recorded in the history. In 1940 in United States of America. This is a picture of death.
Is there an issue?
The technology has gone off. It's not all of them.
Okay, let me try to contact him back. Just hold on a bit. Sorry for the inconveniences. Really sorry for the inconveniences. Let me just go ahead quickly.
Bonyeza nyota kisha nyota kupata mwitu.
Piga *149*03 alama ya reli upate kile unachokipenda, iwe kifurushi cha data, SMS au SMS kati ya maongezi kutoka kwenye mtandao.
Doctor.
Yes, bro.
You're offline.
Yes.
You are disconnected. You're not online.
I don't know if you have any. Okay, let me try to reconnect to the internet.
Okay.
Hello.
Okay. All right. He's trying to connect. If he cannot connect, I will continue from where he stopped. He's not going. Let's just give him a minute. He tried to connect. If he cannot connect, and I'll continue from where he stopped.
All right.
Or in the meantime, maybe the moderator can be taking questions from the audience for our first presenter, while we await Dr. Malanja to sort out his issues. Is that okay, Madam Moderator?
Yes, it's okay. So at this time, I'd like to welcome there was a first question asked during the first presentation. It was asked in the chat by Teophilus Dolo. The question was, he was having two questions. The first one, which diagnostic procedure is the gold standard for confirming stomach cancer? And his next second question was, which lymph node enlargement is classically associated with advanced gastric cancer? You're welcome for the answers. I welcome Dr. Usayo for the answers.
All right. Thank you. So, according to the research that some of the research that I did, as I explained in the presentation, the procedure is upper GI endoscopy. So the procedure is upper GI endoscopy followed by biopsy. So the endoscopy itself is just to visualize the stomach lining, and if there is any suspicion of a tumor or maybe suspicious lining of the stomach, maybe some sort of inflammation that may be suggestive of malignant lesion, then a biopsy can be collected. So the procedure is upper GI endoscopy coupled with biopsy. So the biopsy is what is going to confirm the diagnosis, and it is collected through the procedure of upper GI endoscopy. And the second question that was asked was about, please remind me.
Hello, yes, I'm back.
Yeah, so
Hello.
yeah, Dr. Lucia is
Yes.
responding to questions. Just hold on a bit. Let her respond to the last questions, and maybe we can take you. So what was the second question for Tufel? I think he spoke about the lymph
Yeah, yeah,
node, the
yeah.
specific lymph
I've
nodes.
seen the second question. It's fine. I've seen the second question. So the second question was, which lymph node enlargement is classically associated with advanced gastric cancer? So according to literature, the lymph node is the left supraclavicular lymph node, which is also known as the vitreous node. So this typically um, translates into advanced GI gastric cancer because it's an indication of metastatic spread. So the vitreous node is the lymph node enlargement classically associated with advanced gastric cancer. Thank you.
Okay. So Dr. Malanja, if you are okay now, then we can welcome you back.
So you because using my apartment. So you can practice the presentation. Continue. Yeah. Well, next slide. The next and the next one. This is from here. Uh, define, uh, it is an normal cell or so the normal the normal functions the normal to from the area lines you have abdominal yellow. So,
I think your
so the
line is
other
still
line,
bad.
yes.
I think your line is still very bad. Others, are you others getting him clearly?
Not ready. The line is still
Like
bad.
it. More.
Yeah, I think your line is so bad. All right, let's.
Too bad, too bad.
All right, think I'll pick up from here. For those who are not trying to enter, you have to go to YouTube also, because when I start to present, it will be difficult to admit anyone.
So may I continue?
Yeah, you can continue. Let's see how it goes. Let's see how it goes.
Okay,
Yeah.
sure.
hmm
Uh, uh, sure. So like this localized, it is the thing in the blue lungs, you have the dark blue spot, and also it can go to the other parts of the skeleton. go to the liver is being shown here. How is it? So coming to the anatomy, the second slide, this is the anatomy of the lungs and the physiology. You have two lungs, and the left one is the right one. The different sizes, yeah, sure. So they have lobes. You have that one is having two lobes, and that one is having three lobes. So again, you have the trachea, and you have the upper part of the larynx and the pharynx. The trachea branches into bronchus, the left bronchus and the right bronchus. Also, again, you have other branches, bronchioles. Also, the tail part of any bronchioles, it is called alveolus. Alveolus, as you can see here. It is where the exchange of gases takes place, the exchange of carbon or oxygen. Next slide. So this is a disease study. According to the data from the global can, so lung cancer is the leading cause of cancer deaths worldwide. Also, it is the most frequently diagnosed cancer in 2022, responsible for more than 2.5 million cases, which is equivalent to 12%, which translates into 1 in 8 cancers worldwide. So it is primarily affects those who are in the 6th or 7th decade of life, and the 25% who are affected with lung cancer and 34 40. So, and more than 40% of lung cancer patients, as the disease is in terms of stages at the time of diagnosis. So again, it was responsible for 1.8 million deaths globally in 2028. In 2022, again, it has one of the policies survival. Only about 13% of patients with lung cancer and the survival are beyond 5 years after the diagnosis. So Africa continent is one of the least affected continents in the world, which is only responsible for 2.2% of the global cancer. So most of the cancers are from the North America and the Europe due to the prevalent habit of smoking. But in Africa, it is also observed in the high-income countries involving Egypt and South Africa, and also Nigeria, according to global can. So again, compared to Liberia and the West African countries, so it is relatively low number of cases. This can be due to other factors, which include we don't have the ability to make diagnosis, and many patients may be diagnosed with TB cases or electrical pneumonia, and so they can die in their cases and recorded. So again, these are top 5. Okay. So how does that develop? Is the most important poisons. The most common is nicotine and the others. So these are called the carcinogens, which they can go and cause cell damage, and the cell damage can go and cause response in the cell. So this can lead to changes of the CO2 line would cover the lungs and the trachea. So it can go and create hypersecretion of new you have nicotine addiction, and you have habitual smokers, it is carcinogen, like it exits in the NK. So it patients, this is a changes in your genes. So this can lead to lung cancer. Next slide. So again, another possible way of developing lung cancer can start from infection. When you have chronic bacterial infections, the one like tuberculosis is the most common, the other viral infection can lead to chronic inflammation, and so this can mount into severe immune response, which can trigger malignant transformation and then result into lung cancer. So when you have prevalent tuberculosis cases, there are chances that lung cancer will develop. So we have types of lung cancers. This is actually a slide. Slide. Okay. They are classified as non-small cell carcinoma and small cell carcinoma. This is based on morphology and how you observe the cells, the cancer cells under microscopy. So the most common it is non-small cell carcinoma, which represents about from 70 to 45% of all cancers, brain cancers. Further to non-small cell carcinoma, they are divided into large cell carcinoma, which appears as a large mass at the center of the lung. You have the adenocarcinoma. Adenocarcinoma is the most common, and this adenocarcinoma it is not associated with smoking, although in some cases it can be caused by smoking. So and again it can affect more females. This week I had a case of a 27-year-old lady who was diagnosed with adenocarcinoma of the right lung just 1 year ago, and then by the time she came to Ocean Road, she had already brain met. The cancer was already spread to the brain, so it is common, and it is sometimes the patient was just 27, and there was a lady. So again, she had no any history of smoking. So this can be described by other factors, risk factors, including the radon. Radon is radioactive material, which can result from the radioactivity of uranium in Tanzania and East Africa, so specific belts which are going to have uranium cases and the radon cases. Again, common carcinoma is which appears in
Are you there, doctor?
which doctor can bad.
Are you on?
Still
Dr. Malanja?
yes.
Okay, you can
Can you hear me now?
Yes.
And then I think it will lead to smoking. Smoke, smoke your neighbor or any person by your side, like maybe the couples and the persons who are living under the same roof, and you have the steady smoker. The steady smoker is a new concept. Maybe you would in your car or your apartment, and someone who is not there comes in, and he or she may get the effect. Also, kind of the family history, you have the radon exposure. Radon exposure, as I would describe, developed in the radon. Then you have the pollution, especially in the age of industrialization in Africa. Again, you have exposure to radiation, including radium. After occupational exposure, especially to people who work in industries, people can be exposed to asbestos and other chemicals which are carcinogenic. Also, disease like TB, and also you can have diet which is low in fruits and vegetable. So this cancer is also common in people in the first 70 or 80 decade of life, also among the men. So we have the concept of the 30 years. I can skip the concept of 30 years. So this has the number one, you have a variety cancer in one of the lung. Then it's stage 2 and 3, those involve the medicinal lymph nodes. Also in the stage 4, then you have the cancer going to the other organs. For example, I had a case. I had a case of a patient who had his brain mets. Also, they can go to the liver and other parts of the body, including the bones. So again, for small lung cancer, they can rise irritate the lungs, or they can involve the other parts of the body, like the liver and the other parts. So go to the next slide, and to the next one. So these are the symptoms. So many people with lung cancer don't have symptoms until the disease is it is better stage, because there are very few nerve endings in the lungs, and the tumor can grow without causing any pain or discomfort. So this is the most commonly presented find. When you have persistent cough, sometimes you can cough blood. When you have repeated chest infections, also you can have finger tapping. You have your nails which are enlarged. They are the bit of the nails enlarged. Then you can have patients who have risk of unexplained weight loss. Sometimes weight loss. Also, difficulty in breathing. Also, can have the chest or shoulder pain. Sometimes also can have sometimes tiredness, which is unexplained, or even loss of energy. So even you can have weakness of voice. So sometimes lung cancer, especially the non-small cell lung cancer can have symptoms which are called paraneoplastic, which cannot be explained by the extension of tumor itself or its metastasis, but the secretion of hormones, which are sometimes similar to hormones in the enzymes, so they can explain other symptoms. You know, the most common enzyme secretary is ADH. ADH is involved in the regulation of fluid and the salt in the body, so it can lead to irritability sometimes. It can lead to confusion, weakness, and sometimes can cause seizure due to molecular imbalance. So the next slide. Here, so these are the diagnostic tests. When you want to diagnose lung cancer, is the usually with the X-ray. Some people different with accidental tumor using the routine chest X-ray for the cause. So you can have the CT scan, ultrasound, which uses a type of sugar in the blood and then visualized under the PET, like is shown here. So also the next slide, you can have other procedures, including the bronchoscopy. As you use the bronchoscopy, the other features are all using video. You can have the visualization of the tumor, and sometimes you can take the biopsy. So this is the bronchoscopy. It uses a fiber which is passes through the nose, and then it can go straight to the lungs, and it can go directly visualization of the tumor. So the other parts we can do sputum, sputum cytology. You cough and the secretions are being under microscope, examined under microscope. So this is also one of the screening tools for some patients. So coming to prevention, I would say prevention, the most important is educating the mass. So educating the mass, especially in reducing tobacco consumption, in reducing smoking. So again, you a person have to avoid the secondhand smoke, also to avoid the carcinogen to work, including the asbestos. Also, to the health diet will contain vitamin C and vitamin E, which are known as antioxidant. Also, you can have regular exercise. Regular exercise has risk for lung cancer and the other cancers. So again, we can screening for persons at the higher risk, including those with the history of smoking in their 70s or 8th decade of their life. Also, we can screen for those who are having at least more than 20 pack years. Pack years is a form of for which can tell a risk of lung cancer. It is taken as a number of cigarettes smoked in a single day. The years of smoking divided by 20. So if you have more than 40%, you have more than 40 pack years, the risk for cancer. So I think you can screen among individuals who are at high risk, including those who are having more than 20 years. So in treatment, as with other cancers, so treatment depends on several factors, including the type of the lung cancer. The non-small cell, all the three groups share the same features, so they have the similar approaches to treatment. Also, the depend on the size and position of the cancer. It allows surgical intervention. Also, how far the cancer is being advanced in the development history of the person with the cancer. So you can have surgery. In surgery, we have several features here in surgery. So again, you can have radiation, which can be focused to the lesion externally, or sometimes you can have the internal radiation to use wires, which can be used to deliver radioactive substances, which can cause killing of the cancer cells. So again, to the next slide. So we can go to chemo. Chemo can be before surgery or even after surgery because the remaining. So when you combine chemo with radiation, it is known as chemoradiotherapy. So these are the commonly difficult chemo, which is known vomiting, sometimes hair loss. And then the next slide. This is immune. So this is intentionally targeted therapy, especially in the non-small cell carcinoma. We use some specific immune agents which target the cells and they can kill the cancer cells. So again, it's generally for people with advanced lung cancer. So and some people with the advanced stage in the later, so we can give the palliative care with a target of improving the quality of life when they prolong to some years. So generally, as I've spoken, just 13% of people with lung cancer survive beyond 5 years due to being diagnosed in later stages. So this is the last slide. As I can see the next slide. So this is a lady in Tanzania. She's a queen. So this is a fashion among the university students. The smoke zone is shisha. I don't know if it is even more common in Liberia. Every story may more than in US, United States of America values. So I guess it is common. So this is shisha. It is It
What do you
is,
call
it
it is?
is, okay, it's not a question, so I think it is an English, it is an English word. So, smoking tobacco is the best way ever to prevent cancers. Although you can sometimes smoke tobacco to get cancer due to other factors. So again, this is modifiable. It is within your ability to say that cease to smoke, or even not smoking at all. So this is my last slide. I'm sorry for inconvenience. For inconvenience. So welcome to the moderator.
Thank you. Madam Moderator,
Thank you so much.
it's to you now.
Okay, thank you so much. Thank you, Dr. Malonja, for such a prestigious presentation. Hope everybody learned a lot. We heard about vitamin C and vitamin A, rich in antioxidants, can prevent you from various cancers. We heard about avoiding carcinogens and so on. Now it is the time for question and answers. I hope everybody, people have lots of questions from the first presentation and the second presentation. So I would like us to continue. There are some questions we are asked in the chat. I think the first question was already answered by our first presenter. We have the second question is why stomach cancer is more prevalent in male than female. It was asked by Mr. Alexander Coley. So I will welcome Dr. Lusayo for answering this question. And
All
also
right.
the same person also asked, is FMAC best diagnostic option for pancreatic cancer? So I welcome you to answer both questions.
All right. Thank you so much for the questions. So the first question about why stomach cancer is more prevalent in males than females. So a bit of literature that has explored the risk factors have it has been commented to say that so the risk factors for the stomach cancers are usually more prevalent in the males than the females. So that's the first reason. For example, the lifestyle factors. It is more common. Smoking is more common in the males compared to the females, as well as alcohol consumption. There's higher alcohol consumption in males than females, and it may be debatable, but it has also been shown that
Thank you.
junky food, eating food that is that has high salt intake, or maybe just the smoked stuff. And also there are biological differences, including genetics and issues of hormone factors. So these also basically predispose the male gender more to pancreatic cancer than the counterparts, the females. So on the second question, if FNAC is the best option for pancreatic cancer diagnosis, the answer is no. The gold standard for pancreatic cancer diagnosis is the biopsy. So biopsy is what a biopsy, like a core needle biopsy, or maybe if a surgery has been done, then maybe they can be like resection of the tumor. So this is what is going to give us a gold standard for the diagnosis. If FNAC is done, it has to be coupled with other investigations. So, but the gold standard that is usually preferred by the surgeons and the pathologists is the biopsy, core needle, as well as maybe excision biopsy. Thank you.
Thank
Thank
you,
you.
Dr. Lusayo. If I'll still welcome you if you have a question. I still welcome you if you have a suggestion. You can put your suggestion in the chat or your question in the chat so that our two presenters can see them and be able to contribute to them. Moving to the next question asked in the chat. The question was, what is the prognosis of the pancreatic cancer? The question was asked by Chano Zoga. I think
All
this goes
right.
direct to Dr. Lusayo.
Thank you for that question. So as we discussed in the presentation, the best 5-year survival rate from localized disease, 5-year survival rate is about 40%. And if the disease is advanced, like the patient has metastasis, the survival is usually less than 3%. But in general, the cross-cutting 5-year survival rate it has been rated to be from 5 to 10% in the different studies that have been done. So as we already discussed, more than half of the patients, they present with stage 4 disease. So that is what makes pancreatic cancer difficult to manage, and that also contributes to the poor survival rates. Thank you.
Thank you, Dr. Lusayo again. Anybody having a point of addition to add, or anybody who wants to ask a question to that? Okay, I think it's understood. The next question was asked by Alexander Coley. He asked two questions. The classic triad of pancreatic. Okay. I didn't get this first question,
So I think he's
but
asking for it's a classic triad for pancreatic cancer. Where I don't know if whether it is prudent because since this is an awareness thing and some people might not be a medical practitioner to discuss this in-depth medical terminologies, but for the purpose of responding to his question, Dr. Lusai, do you want to respond or you want me to respond to that? Hello? Okay, so we'll go on. The classic triad that is usually used that's when we speak medically will be considered the epigastric pain. Usually, you have epigastric pain that will most often radius to the back. You have jaundice, especially the obstructive type, and then of course you can have weight loss, and usually weight loss can, it occurs in almost all cancers. So you have these specific ones where you have this epigastric pain that radiates to the back, and that of the weight loss, and that of obstructive jaundice so far. And now for the imaging modalities, usually you have contrast enhanced CT scan like that you use for diagnosis of such. But I will want us to tailor our question toward something that you know people of non-medical background can be able to benefit more rather than just limiting it to we the medical people. If there's a point at which we wanna go in depth, we can still be able to have some further discussion. But we want it to be something that will be beneficial to the entire participant, since we are a mixture of medical and non-medical practitioners. Thank you.
okay, thank you, Dr. Elvis. And there's a question here asked by Topilas Dolo. The question is, why pancreatic cancer is often diagnosed at an advanced stage? why pancreatic cancer is often diagnosed at an advanced stage.
Dr. Lisaya, do you want to respond?
Yeah, I can respond to that one.
Okay.
So, as we discussed in the presentation, early stages of pancreatic cancer often has few or no symptoms at all, because as we discussed, the pancreas itself, it's quite a deep organ. It's not superficial. So it's even the some of the pressure symptoms that the patient may have, a patient will rarely come in the early stages. That means the disease is localized, it's minimal. So because of the absence of symptoms of early disease, usually we rarely diagnose pancreatic cancer in its in its early stages. Rather, we diagnose it usually when it has metastasized, or it's putting pressure on the surrounding organs like the stomach, the intestines, and the liver. So it is also known that the pancreas, the tumor itself, it is quite aggressive. So as we may know, some cancers, they spread quite. They grow quite in a short period of time, and others are quite slow growing. So pancreatic cancer is one of the fast growing cancers. So I think if I can stop there, that may suffice the question, to answer the question that has been asked. Thank you.
So just to make it in a nutshell, it's just that um, because of the lack of signs and symptoms at when they are at the early stages, that's the main thing, that's the main reason. In addition to all other things doc have said, so maybe I can be a take home message.
Yeah, yeah, and we also discussed about the lack of
Yeah.
screening techniques.
Mhm.
So as we may know, some cancers like the cervical cancer, it has a well-known screening program. So that is why we are able to find some of the cancers in early stage. But for pancreatic cancer, there is no approved screening procedure. I mean, screening program or procedure that can be done. So usually the patients, they present quite in advanced stages.
Okay.
Thank you.
Okay, thank you so much, Dr. Lusayo and Dr. Elvis, for the answers. There is another question. Um, I am asking myself. I'm asking about lung cancer. The question is, can the radioactive substances in the air we breathe expose you to have any type of cancer rather than lung cancer only? I would like to welcome our lung cancer presenter for answering. Thank you.
Uh, okay, sure. You can have, especially the blood cancers, the leukemia, specifically the leukemia. So it is again commonly uranium belt region. If you are from Tanzania, that from Bahi coming to Singida, Bahi is in Dodoma, coming to Singida, and sometimes going to Monyala, all of the way. There may be cases of leukemia, the blood cancer specifically. Again, another factor that can be also implicated is gastric cancer. That might be the case for Japan, not Japan, Hiroshima, yeah. That can be also the case. So there can be other types of cancer apart from the lung cancer, can do the stomach and the body cancer.
Thank you. Thank you so
Okay, Yeah. Okay, sure.
Yeah, you're done?
Yeah, that's
All
Yeah,
right.
sure.
There are two questions here, but I would I would like to ask if you allow me to present, I mean to ask them here, or we should proceed to our next
Let's continue with Mrs. Diallo. Since she has questions, she said for cancers like gastric, pancreatic, and lung, how do doctors determine whether chemotherapy is the best treatment option? And is it ever possible that chemotherapy could worsen a patient's condition? Well, um, in the treatment or in the management of cancer, it, we treat patients on a basis of the published or researches that have occurred and they have been conducted and then proven to show promise in these populations in which the studies was conducted. So, and most of them, like the presenter said earlier, they are they are on a basis of the stage at which this cancer present. So if you have a more early cancers conditions, like it was mentioned, wherein there is no metastasis, you can easily treat such a cancer with just surgery, and then at some point maybe follow up with chemotherapy. And some of them are the specific types of cancer that do not respond to um, chemotherapy, just like that. It will refer it will prefer or preferably in response to radiation therapy. And some of them also will not respond to radiation therapy, they will respond to chemotherapy. And then also you have to include the targeted or the immunotherapy. So based on studies that have been conducted by pharmaceutical industries, by cancer experts, it is on the basis of that we decide which treatment regimen can be used for particular patient. And of course, for chemotherapy to worsen the condition of a patient, well, it depends on the assessment being done, because before we treat a patient, we look at several parameters. We don't just give the medication to the patient like that. We look at several parameters, and one of these is the patient performance status. So if we see that our patient performance status is poor, that the patient is not able to do anything for himself, is bedridden and things like that, we might not opt to go for chemotherapy instead or for particular therapy. Instead, what we intend to do, this is why you heard the doctor said it involves multidisciplinary team, like the dietitian, the nutritionist. We involve them on board to be able to make interventions. So when the performance status of that patient has improved, before then we include those chemotherapy, because these medications, they work on fast growing cells. So at the end of the day, it has a way in which it will have its own effect on the patient. And even any other medication you take, these are things to consider before going to treat the patient with either chemotherapy or radiation therapy. Now the next person said, why does pancreatic cancer often present late? I think the question was answered previously by Dr. Lisayo. It is mostly because of the lack of screening programs and that of the lack of early signs and symptoms. So before you get to know, maybe it is impinging on some of those vital organs, and then thereby leading to a downstream signs symptom. Maybe, for instance, if it is obstructing the biliary system, then you see jaundice, as in the case here, and so forth.
Okay. Thank you so much, Dr. Elvis, and thank you everyone for listening attentively to this moment and asking questions. And thanks to our presenters. Moving forward, we wanna uh, move to the closing
Last,
remarks time.
last, let me just respond to this question. Who is at risk of lung cancer? Those who smoke, and those who said by people who smoke, like those who take the shisha, and shisha is common in Liberia. To answer your question, Dr. Malonja, it is common in Liberia, just as it is here. And asbestos, those who work in industries that deals with asbestos, and those who are in an environment where there is a random gas, the radon gas. So when the radon gas seep into the house and is inhaled, it travels through the gastric system and then the nasal system and then goes into the lung and irritates the lung lining. And over a prolonged period of time, it leads to development of malignant changes, thereby resulting into the development of lung cancer. So these are people that are at risk of lung cancer. Thank you. So you can go on now with your, because I think we are beyond time now, almost 19, 10 minutes now beyond time.
Okay, thank you, Dr. Elvis. I would like to this it is now the time for closing our meeting and finalizing, and I would like to welcome Honorable Dr. Elvis J. Davis this time for closing remarks. And soon after he finishes, we'll welcome the person who will do for us a closing prayer. So welcome a lot, Dr. Elvis.
All right, thank you. I will start my statement by saying, by responding to this question from Ada. She asked if a child at 10, between 10 and 15 years can get stomach cancer. To my knowledge, I'm not aware of such, because usually these are disease conditions that are associated with adult age. So I have not come across any paper that have made or published on child getting gastric cancer. But we're gonna continue to make research. If there is any, we're gonna make publications of that, or maybe we can be able to share that with our audience in subsequent time. Thank you. So to continue, I like to first apologize to everyone for the issues we had tonight with our internet connectivity. I guess we are aware that we are all in Africa, so one way or the other we have some issues. So we are very sorry for tonight. But I also want to conclude to say thank you to everyone for your participation, your patience. I mean, to stay up to this time. I want to say thank you so much. And we look forward to more knowledge being shared. We look forward to more participation. Let us continue to get people on board who can be able to get knowledge and share in our various communities. Thank you. And lastly, the issue of our certificates, there have been a problem with our IT team. The link was prepared and then shared to the IT team, but it seems that they did not find the document. So because of that, there was a delay in printing our certificates. But we are hoping that between the first and second week of December, the certificates will be ready and to be distributed among our participants. Thank you so much.
Thank you, Dr. Elvis. Thank you, Dr. Maloja and Dr. Lucius and the Master of Ceremony. Thank you. It was a pleasure of sharing for you.
Okay, now at this time, we would like to do a closing prayer, and I will welcome